Alright. Hey there, NeuroClarity crew. Welcome back to your favorite neurology podcast, where we break down the brain and all its complex mysteries in ways that actually make sense. Today, we are taking a deep city dive. This is not just any dive. We are reading the shadows of a stroke and we are going to learn how to map the power outage in the brain, just like a neurologist who has a double degree in electrical engineering. Now, before we start, I would like to give accolades to whom accolades should be given to. Dr. Lee Ali Ali, who is known as Teach Play Grub on Twitter, is a neuroradiologist at Bureau Neuro. And goodness me, her tutorials on stroke and imaging has really helped me a lot. In fact, pieces of her tweets make up a huge core of the foundation of this video today. Also, our case is derived from Ching and Cheng's comprehensive review of clinical neurology. And this is question 45. We've done questions 1 to 44. That being said, let's set the scene. Question 45. A 59-year-old man presents with sudden onset of right hemiparesis and aphasia. The National Institute of Health Stroke Scale (NIHSS) score is 18. A brain CT scan is obtained and you calculate the Alberta Stroke Program Early CT score aspect. Which of the following is correct? A. A score of 3 supports the use of intravenous tissue plasminogen activator. B. 3 CT scan slice cuts are required to calculate the score. C. The maximum score is 20. D. A score of 7 or less is associated with increased dependency and death. And E. The minimum score is 3. By the end of this video, you should be able to pick the right answer. Let's paint this scenario a little. You are called in for a 59-year-old man who suddenly developed right-sided weakness and can't speak. These are classical signs of a left MCA stroke, as in a left middle cerebral artery stroke. We are told his NIHSS score is 18, which signifies a moderate to severe stroke. This is a significant stroke. A non-contrast head CT is quickly obtained, and now you are asked to calculate something called aspect score. So, what on God's green earth is aspect and why does it matter? Buckle up. You are about to become fluent in stroke CT reading 101, but with a twist.
Are you ready, kids?
Aye, aye, Captain!
I can't hear you.
Aye, aye, Captain!
Oh! Who lives in a pineapple under the sea?
SpongeBob SquarePants!
Absorb.
Time out. What is aspect? Aspect stands for Alberta Stroke Program Early CT score, and it was designed to give us a standardized, reproducible way to estimate how much the middle cerebral artery territory is infarcted. Instead of just eyeballing the scan and guessing, oh, this is a big stroke, you actually have a standardized way of demonstrating how bad the infarct is. Now, imagine trying to describe a city blackout during a terrible storm. The brain here is your city, and the MCA territory is like the city grid. As long as blood is flowing, brain tissue lights up and everything on the grid is powered on and functioning. But when a stroke cuts off blood supply, boom, sections of the brain go dark, like neighborhoods losing power, and that's where aspect comes in. The stroke scorecard. Aspect is a 10-point score, and here's the simple magic. You get 1 point for each MCA region not showing signs of infarction. That is, if the brain looks normal, the lights are on and you have a full point. If there's low density, that's darkness, that sector has lost power and you lose a point. A perfect score of 10 means there is no visible damage on CT, and a score of 0 basically tells us that the entire MCA territory is infarcted and there is a complete blackout. How do you score it? Let's think of the MCA territory like a map, broken down into 10 neighborhoods. These are grouped on 2 levels on CT. The first slice or the first level is what we call the ganglionic level. Let's call this part the Krabby Patty Town. Here, you see 7 regions, 3 deep structures, 1 insular ribbon, and 3 cortical regions on the outside. The 3 deep structures include the caudate, the lentiform nucleus, and the internal capsule. The 3 cortical regions on the outside include the M1, M2, and the M3 segments, and in between is the insular ribbon. The cortical regions are labeled M1, M2, and M3. M1 is at the frontal lobe, and when you think M1, think Broca's area. M1, Broca's area. M3 rhymes with Wernicke. Wernicke, M3. So when you see M3, think Wernicke. In between M1 and M3 is M2. So M2 is in between. If you look closely, this resembles a Krabby Patty, with the deep structure being the bones, the insular being the patty, and the M1 to M3 region being the fries. So you have a beautiful Krabby Patty.
Live from downtown Bikini Bottom. Complete chaos here today as our town attempts to deal with a sudden and complete shortage of Krabby Patties. Whoa! Events here have this reporter wondering, what is the secret ingredient in Krabby Patties anyway?
It's love! The secret ingredient is love!
Oops, sorry SpongeBob, we just unraveled the recipe. Next is the supraganglionic level. Let's call this the fries level, right above the Krabby Patty town. Just above the Krabby Patty town, you get 3 more cortical regions, which includes M4, M5, and M6. Now, M4 is directly above M1, M5 is directly above M2, and M6 is directly above M3. There are no deep structures in here, just finger-like gyri reaching up like crispy fries. And there you go, 10 total sectors. If all 10 looks good, then you have a score of 10. If 3 sectors are dark, you lose 3 points, and your aspect score will be 7. Next, why does aspect matter? Aspect matters because it guides treatment. A high aspect score of 8 to 10 tells us that there is a small infarct and the patient may benefit from a TPA or thrombectomy. A low score of 0 to 5 represents a large infarct, and this generally translates to higher risk of hemorrhage with treatment. Generally, an aspect score of lesser than or equal to 7 is associated with worse outcomes, more dependency, and death. This scoring gives us confidence and clarity. Get that? Clarity. NeuroClarity. Rewind. This scoring gives us confidence and clarity in what used to be guesswork. Instead of saying, "Ooh, that looks like a big stroke," you can now say, "This patient has an aspect score of 6, likely an infarction in the insular, M1, and internal capsule." And boom, you already sound like a pro. Next, let us tie it back to our patient. He has an NIHSS of 18, which indicates moderate to severe stroke. We expect some visible damage on the brain CT. Let's say the aspect comes back as 5. That tells us that half of the MCA territory is infected and treatment decisions need to be made carefully. The higher the NIHSS, the more deficits clinically, and the lower the aspect, the more tissue is already infected radiographically. So now, you are not just seeing the blackout, you are mapping it, naming it, and treating it. Recap round. Let's hit those high-yield pearls one more time. Aspect is basically a 10-point score to estimate infarct size in MCA strokes. Each point equals to one region that's not infarcted. There are two city levels, the crappy party and the fries, or the basal ganglia level and the supra-basal ganglia level. A score of 10 is the maximum score you can ever get, and basically that tells you there are no visible infarcts. A score of 0 is the minimum score you can ever get, and that tells you there's a full MCA infarct. A score of lesser than or equal to 7 indicates caution for thrombolysis, and it also tells us that these patients may have an increased risk of dependence and death. Combine the NIHSS for clinical plus radiological clarity. When you see a stroke, think CT blackout, and aspect is your outage map. Now, back to our question. A score of 3 supports the use of intravenous tissue plasminogen activator, that is TPA. This is false. And why is it false? Any score of lesser than or equal to 7 indicates that giving a TPA can be very risky, especially in the setting of a high NIHSS score. Next, 3 CT scan slice cuts are required to calculate the score. That is false. Remember we said there are two slices, crappy party town and fries town, or the basal ganglia town and the supra-basal ganglia town. So that's false. C. The maximum score is 20. That is false. We said the maximum score is 10. D. A score of 7 or less is associated with increased dependency and death. That is true. E. The minimum score is 3. This is false. The minimum score is 0. Alright, NeuroClarity fam, before we wrap up, let's not forget about a whole other territory that does not get scored by the aspects, the posterior circulation. This includes your brainstem, cerebellum, and occipital lobe, which are the backstage crew of the brain. They don't get enough spotlights, but they run the show when it comes to balance, breathing, consciousness, and vision. Unlike the anterior circulation, where aspect fully applies, the posterior stroke can be very sneaky. Patients may present with vertigo, double vision, dysphagia, ataxia, or even sudden coma. And guess what? This stroke might actually look normal on early CT because the brainstem is tiny and hard to visualize. That is why, for suspected posterior stroke, MRI is your friend and clinical suspicion is everything. So, while aspect is great for anterior stroke circulation, posterior strokes reminds us to keep a wide differential and never ignore subtle signs. However, there is something we call the PC aspect, the posterior circulation aspect stroke. And just like its cousin for anterior circulation, this stroke uses a non-contrast head CT or DWI MRI to semi-quantify how much of the posterior circulation territory is already infarcted. How does this work? You start with a perfect score of 10, meaning there are no visible infarcts. Then, you subtract points for each of the critical posterior structures that show sign of infarction. 1 point for each side of the thalamus, 1 point for each side of the occipital lobe, 1 point for each side of the cerebellum, 2 points for any midbrain involvement, and 2 points for any pons involvement. That's a total of 10 points. And just like in anterior aspect, the lower the score, the worse the infarction. A score of lesser than or equal to 8 has been associated with poor outcomes and higher risk of complications post-thrombectomy. Note again, posterior strokes can be easily missed, so if you are dealing with someone who is dizzy, ataxic, maybe even comatose, and you see subtle hypodensities in the brainstem or cerebellum, bust out your PC aspects to help guide decision making and prognosis. Aspect lights up the front of the brain. PC aspect maps the power grid at the back, and now you are fluent in both languages. Whether it's the broker's crappy party or the brainstem's blackout, you've got the NeuroClarity to read the signs and act fast. That's it for today's episode of NeuroClarity. If you found this helpful, please share it with a friend, like, or drop a review, or better yet, Light up someone else's brain with this knowledge. Until next time, stay curious, stay brilliant, and keep those mental lights on. Bye for now.